All right, we're ready to go.
All right. So as Julia mentioned, I'm Dawn Laney. I'm a genetic counselor down at Emory University in Atlanta, Georgia, down in the United States. And I've got to go to this great meeting, and Julia and Donna got to go there as well. This is a meeting where we have people just from around the world, and we're all thinking about different lysosomal storage diseases, and Fabry is just one. And this was, in truth, not a real heavy on the Fabry disease year, but there were some great posters, there were some great presentations. So my goal is to kind of walk you through some of the things we learned this year. And I'm going to disclose before I hop in there that I do get grant funding from Sanofi and from Amicus. I'm a research coordinator for a lot of trials in Fabry disease, which is really exciting. But at the same time, it means that I know things that I can't necessarily disclose to you, but anything that's published, I can talk about. So keeping that in mind. And I do get honoraries for speaking. My other disclosures, my children are wandering around, so occasionally one of them is going to pop in. Nothing I talk about here is medical advice. Even if this is the coolest thing you ever heard and you're like, I'm going to hop right on that. Don't hop right on that. Talk to your doctor before you do anything, or if you move anywhere when we're thinking about something that might impact with Fabry disease. And so the way I kind of laid this out is for some of the slides and some of the studies, I thought we needed a little background research. So some of them I'll ease into by talking about something that you may already know, and then tell you what's cool about what we just learned. And in some cases, I'm just going to jump on in there, and there's so many words, and I'm just going to tell you the summary. It just depends on which study we're looking about. Okay, so one of the things that came up again is that in Fabry disease, classic Fabry disease, we know by definition you expect to see symptoms start, particularly in children who are, we think about them as being maybe 3, 4, 5 that we expect to see symptoms. And this was just another study that looked at 5 boys who were down in Argentina, and they monitored them without treatment for the first 3 years of life. And what they showed is that the biomarkers we measure, those lyso-Gb3s, were elevated in those boys. And the most common thing that they felt was belly pain and diarrhea. And then after that, they started having problems with the heat and pain in the hands and feet after that. But really what they showed is the first time someone has a symptom that can be identifiable is about 21 months. So that's slightly under 2 years of age, which tells us again that Fabry symptoms start early and that we need to be aware of them. The other thing we really focused in on for a couple posters is that Fabry, we always talk about the storage and how the storage of GB3 and lyso-Gb3 happens in those lysosomes in the cells that line our blood vessels, narrowing the blood vessels and causing problems when you don't get enough blood to, your nerves or your GI system or your heart, things like that. But one thing we've learned more over the past little bit is that it's not just the storage. It's the storage actually activates your immune system to get irritated. And when your immune system is irritated, it starts what's called an inflammatory response. Inflammatory response just means that all those great immune cells that are supposed to protect us are attacking those cells that have too much of these GB3 and lyso-Gb3, and it ends up killing those cells, and then you get scarring, or what we call fibrosis. So just think about it as we always thought about storage, but now you got to think about storage and how it activates your immune system and causes problems. So we're like, okay, we know that's a problem. Okay, moving on. One of the things that is sending out all the signals and telling your body that there's something wrong with this cell over here is called an inflammasome. Doesn't that sound like it should be on like the X-Men or something? So this inflammasome is in a cell and around the body. And what it does is it sends out these signals, these capsinases, and they activate other things, interleukins. So all these it all sounds like science fiction, I know, but basically think of it this way. Within your cell, there's this thing called the inflammasome, and it's sending out signals. And these signals feed back pathways, and makes your immune system sit up and pay attention. And when your immune system is paying attention to the cells that have storage of GL3 or GB3 or lyso-Gb3, it's not spending as much time making energy for your body. So your mitochondria is not working as well as it should. And it's going to work on killing off those cells that have too much storage because it sees them as a problem. That's a lot, right? Okay, think about it. Stuff stores, it tells your immune system that it's an irritated cell, and then it starts this whole cascade of events that means your body is having a response that makes you more tired because your mitochondria aren't working as well, and can lead to cells dying and then making a scar tissue. So what somebody did, so that means we should use our primary therapies, like our enzyme replacement therapies and chaperone therapies and all the other cool therapies coming down the road, to decrease the amount of GB storage. But we also need to think about other treatments we need to think about. And this was just a study that was looking at what you need to do, thinking about it from the heart perspective. And it was saying we probably need to start thinking more about how to decrease inflammation, as well as decreasing the amount of GB3s and lyso-GB3s, as well as the other things we do, like if you've got protein in your urine, looking at ACE inhibitors, ARBs, things that decrease the amount of protein in your urine to help protect your kidney. So and if you've got burning pain in your hands and feet, we talk about medications you can take to help with that some. We also need to think about how to decrease inflammation in the body. So one thing you can do, I told one of those signals that your inflammasome is sending out is called a capsase. Capsase? Anyway, so one of the things you can do is measure the level of that signal. So what one group did is they measured the level of capase 1, so that's just one of those signals that goes out from an irritated inflammasome, and said, okay, what are the levels in these cells from blood that we took from patients with Fabry disease and patients who didn't have Fabry disease? And let's measure what happens like before, after we give basically the equivalent of medication that's called a capase inhibitor. And then let's look again and see what the immune system's doing. So this is just a test this was just a study that was being done in cells from people with Fabry disease. They didn't give people with Fabry disease anything like in their mouth or medication or anything. They just wanted to see proof of concept. If they took a cell that it has the storage and has inflammatory activity, and they gave this broad capase inhibitor, it did pull down the levels of different immune signals, and it made less capase 2, and those cells stayed alive. So they didn't get killed off by the immune system. So once you've got it in cells, then you would move to different animals, right? Then they would go to mice, and they go to rats, and then they go to humans. So it's a fair way away, but just know that people are trying to solve the problem of if Fabry storage causes inflammation, can we help that inflammation as well as getting rid of the storage? And that hope would be down the line, it would keep those cells from getting scarring from this inflammation. So while we're thinking about that, right now what we do for biomarkers, so things that try to tell us how treatment's working or how severe someone's disease is, that would be GB3 and lyso-GB3, right? We look at it in urine, we look at it in blood. And the question some people asked was, can we do better? Like, can we do something better than just looking at GB3 and lyso-GB3? Because it's not great. And Christine Blaise, who is one of your countrymen, she does amazing work, and she worked with a group that's overseas in Europe. And what they did is they said, okay, if we look at GB3 and lyso-GB3, but we look at all the different forms of it, because just because GB3 builds up the way it does and lyso-GB3 builds up, doesn't mean there's different versions. So like different molecules are added or taken away, so they're called analogs. Just think of it as different versions of GL3 and lyso-GB3. So the question was, could we look at those levels in women and figure out when somebody might need treatment earlier, or someone who's going to have more severe disease or less severe disease? And their answer was, yeah. For some women who had real severe Fabry symptoms, they found that some of these patterns of different types of lyso-GB3 and GB3 were elevated in a pattern that could maybe guess when somebody might need therapy. Is it perfect? No. Of course not. But it was one of those things where they could measure it and see, and they correlated. This woman's having symptoms and was about predicted to start therapy. But if you looked at these levels of GB3, these different forms, could we also say like, oh, based on these GB3s, it is time to start therapy? Because we would not really do that right now. We don't tend to treat based on biomarkers. But they found a connection between what you're feeling and what they could see in these different forms of GB3. They also looked at it in men with men who have Fabry disease and had gene changes. They weren't sure if it causes disease or not. And this pattern also helped determining if they have a disease that could cause classic Fabry disease or not. So she found a great way to look at different forms of GB3 and lyso-GB3 that may be more effective. Again, biomarkers, not perfect, but a little bit better. All right, so thinking about GB3 and all its analogs, one of the things we do know is that it stores in the deep filtering units of the kidney. So when I say podocyte, I want you to picture like these weird giant octopuses, and they're in your kidney, and their job is to filter out all the things that come through your body. And if we get them filled up with lyso-GB3 and GB3, then they don't work so well. And then gradually they get burned out and die because of the storage and inflammatory response. We do know that when you look really closely at podocyte cells from the kidneys and you look at them before treatment and after treatment, you can really make a difference. There's less stuff stored, less inflammatory response. It's looking better. Not perfect, mind you. You can't fix everything, but. So the thing is, it takes a really long time to do a good job counting these cells. So if you look at these podocytes under the microscope, one thing they do, it's very sneaky, is the cells get smaller when you start to take gunk out of them, which means that it may look like they've got more storage, but they don't. It's imagine like if you had a bunch of M&Ms and you stuck them in a balloon and you'd be like, oh, there's 12 M&Ms, but in a really big balloon. So it feels like there's some room in between them. But then you took some air out, you'd be like, oh, there's still 12 M&Ms, but the cell is smaller. It's less irritated. It's having less problems. So what they did is they found a way to use machine learning to get kidney biopsies and then have the machine learning look for patterns based on grids and be able to interpret whether or not cells are not only shrinking, but having less storage of GB3 and lyso-GB3 in those deep kidney cells. This is important because right now there's only a couple places in the whole world that can do this process. But if they were able to teach different pathologists how to use these machine learning processes, then we could do a better job of measuring what's going on. So this one is more of a process thing, but if you have a kidney biopsy, what they're going to look for is your storage of GL3, and they just found a better way to look at it so that it's not one pathologist spending 2 days looking at your kidney cells. This could be a matter of an hour. So big deal for people who look at kidney cells. Big deal for you guys too. But could we use this podocyte thing to learn more about people on the spectrum of more severe classic Fabry disease and what is still very lymph impacting, but a little bit more mixed bag in non-classic Fabry disease? Of course we can. So one thing that we learned from the same people who came up with that machine learning thing, this is one of those brilliant pathologists who focuses on kidney cells all day long. And what he found is that when you look at the kidney cells for people who had classic Fabry disease and those that had non-classic or later onset Fabry disease, those kidney cells were having problems. They were having problems with how their podocytes were working and how full they were and how they were impacting how they work. So what that told us was, if you've ever heard the term heart variant or cardiac variant Fabry disease, we now at this point, we shouldn't say it, because even people who had non-classic Fabry disease or later onset Fabry disease had storage in their kidney cells. So that's a great example of when you use good technology to try to solve an issue. And they were able to say, hey, it looks like that storage has impacted kidney cells, whether or not you have classic Fabry disease. So that helps us learn a little bit more about what we call non-classic or later onset Fabry. I never really liked saying cardiac variant anyway, because I see lots of people who had later onset or non-classic Fabry disease who had stuff beyond the heart. So I was just supporting my bias, right? Okay, so while we're talking about machine learning and AI, there's two cool studies that came out. I only talked about one here, but what they're trying to do is use really big sets of data that had lots of information about people with Fabry disease and people without Fabry disease. And they said, well, can computer artificial intelligence and machine learning predict who has Fabry disease and an increased chance for having atrial fibrillation, which is an arrhythmia of the heart, or ventricular tachycardia? Ventricular tachycardia, there we go, which is a fast and dangerous arrhythmia. And so what they did is they used this big data set and they said, okay, go look for patterns, computer. And the computer went through and it looked for patterns and it did find some things. So about half the time it found the risk that everybody would have for having an arrhythmia like those two things. Mind you, we're only looking at two different arrhythmias. And they found those are things like general cardiac health. So do you have high cholesterol? Do you smoke? Are you overweight? All those things that you would normally think of with increasing the chance to have arrhythmias. And they found those also, they also play in Fabry. So even though Fabry isn't associated with high cholesterol, even though Fabry isn't associated with, diabetes, if you have those things, whether you have Fabry or not, it increases your chance to have an arrhythmia. But they also found a few other things that could predict when somebody might be having an arrhythmia. And that was just interesting. They didn't list out exactly what they all were, but it's suggesting that maybe in the future, AI using these patterns can guess who might be at higher risk to have an arrhythmia, which means we could put in a pacer or a defibrillator early in some of those folks, or keep a closer eye on things, maybe do an implanted monitoring device. They did a similar thing trying to figure out to guess who might have a stroke. Again, not perfect, but kind of heading in a way that could help us learn more about who's at risk for certain complications. Now, many of you may participate in this particular study, but they reported the results at World this year. So there was a study that they asked people to fill out, and it was focused on 280 adults with Fabry disease in North America. So Canada, through CFA and through the different organizations down in the United States that focus on Fabry disease. And what they're trying to figure out, are there people who still have symptoms and see the room for additional therapies? And how well do you know what's going on when people are monitoring you? So they had 208 people in the study who were on ERT, 26 on chaperone, 9 who had been RT but weren't anymore, and then 28 who'd never been on therapy, and 9 more who were doing something else. When they were talking to these people, they said, hey, just curious, or when they were doing the questionnaire, they're like, hey, any chance you know about anti-drug antibodies? Now, if you look at the recommendations for people who are on enzyme replacement therapy, they ask you to draw some blood before they start therapy, usually 4 times for the first year, and then twice a year from then on out. And what we're looking for is antibodies to enzyme replacement therapy, or antibodies to alpha-galactosidase A. That's that enzyme that's missing when you have Fabry disease. And for enzyme replacement therapy, we're giving it back to you in your arm through the IV. One of the things we're supposed to measure is, hey, is your body having a little immune response to enzyme replacement therapy? We know that many, many, many people have antibodies, and it doesn't appear to greatly impact the effectiveness of enzyme replacement therapy in many people. Some people have big problems, whether they have infusion reactions or the enzyme isn't working as well as it should because it's getting neutralized by all those antibodies, so it's keeping it from working as it should. But 42% of people didn't even know if they'd ever been tested for antibodies. So if you're listening to this call, just know that it's worth asking if you've ever been tested for antibodies, then you'll know. And then ask what the result was. Was it positive? Was it negative? There's different types of antibodies. One is called IgG. That's the one that goes up. And most people, not most, many people who get enzyme replacement therapy have that. There's also neutralizing antibodies. Those are the ones that many people also have, but for some people it causes problems with how effective enzyme is working in their body. Anyway, so what they found is that lots of people didn't know about anti-drug antibodies, which told us as providers, we have to spend some time educating people about anti-drug antibodies. And that's something we need to see in the future. The other thing that's interesting is we haven't spent enough time on this, but a little bit over half of patients who had ever been on ERT said that sometimes they had temporary symptoms in between infusions that got worse. So when I hear about it as, oh, I started getting pain and I knew it was time for my infusion, or, ooh, I was getting really tired, so I knew it was about time for my infusion. So people who started feeling things that kind of warned them that, you know, their every 2-week infusion, it was time for that infusion. And that's what they're trying to capture. And they're just saying that, hey, people are reporting they're having some increase in symptoms before it's time for the next infusion. So that's kind of what we're thinking about there. Just listening to you guys, hearing what you're saying, and finding places where you can do more education, or where there's opportunity for a different type of therapy or a different way of doing therapy, or trying to figure out dose changes or whatever we need to do from there. This is really just fact-finding mission. And then we need to figure out what to do from there. Okay, so I divided this up a little bit. So the next thing I'm going to talk about is some of the things they talked about with therapies that are already approved and available to you in Canada. Well, therapies that are approved, and then you know, working with your physician to see if it's a good thing for you or not. One of the things that was a great study is that this is a great group. This is the Argentina group again. And they were saying, how do you know when to start enzyme replacement therapy? The guidelines are kind of wishy-washy, even with classic Fabry disease, on when you start therapy. The international guidelines they were using said starting after the age of 8. And as they already showed in another publication, we're seeing symptoms starting as young as 3. So they were just trying to figure out, if you start early enough, can you make it so that people's levels of GB3 and lyso-GB3 completely go down to 0 or normal? Because we know that when people who are older start therapy, we don't necessarily get it down to that 0 level. We can't get it down to normal. We can get it down a lot, but we can't get it down to like where your average person is. And so there's been a couple publications, Arends, they're over in Europe. They reported that they found that if you start therapy before 25, then you can get those GL3 levels in the blood down lower and lower and lower compared to people who started after 25. And there's another one who said, okay, in classic Fabry disease, we had 2 pediatric patients who were started early, and we could get those levels down to normal level. And so in Argentina, they're like, well, how about us? And so they found 2 girls with classic Fabry disease. They started them before they were 15, and they had symptoms. They had high levels of lyso-Gb3 in their blood, and they were with treatment able to pull that down so that they had normal GL3 levels. So what your average person would have, not somebody with Fabry disease. And then their symptoms decreased as well. So what they concluded was the earlier you start therapy, the better it's going to be, particularly when we're talking about classic Fabry disease. Then the Fabry outcome survey people. So these are the folks who have a big giant registry around the world. There's 2 of them. There's Fabry registry with Sanofi, and there's Fabry outcome survey, which is Takeda, which used to be Shire, which used to be TKT, which is about Replagal or agalsidase alpha. This is the agalsidase alpha one. So this is what they decided to look at. They said, okay, if you treatment earlier, is it more effective? And they used their large big data set that had more than 19 years of data for each of these people. So they tried to get men who started therapy less than 25 years of age, and then had a big instance of data after that. So they looked at people who started early, under 25, and they compared to people who started later, over 25. And they looked at eGFR, so that's a measure of kidney function. Now, all of us, as we get older, our eGFR, that's our estimated glomerular filtration rate, it goes down, it's negative, just kind of slopes down as we get older. But when you have Fabry disease, it slopes down faster. So men with no treatment in the past, their change would be negative 6.8, just for comparison. When they looked at early treatment, so those under 25, they found the rate was negative 1.45. And if you started over 25, it was negative 2.84. So if you think about it, to me, it looks like this. No therapy at all, your GFR is on a fast slide down. If you have GFR after 25, it's still going down, but less than half of what it had been, like much less, like a third of what it had been with the decreased rate if you start therapy after 25. And then if you started before 25, the rate is about where it is for everybody else in the world. So that's pretty cool. So earlier therapy before 25 made a difference with this population. Again, this is people around the world. Then they looked at the heart value. So there's the heart value that is the, what is it? It's a left ventricle height, something index. Anyway, this is a measurement of left ventricle hypertrophy, basically. It's called LVMI. And what you want is it to stay stable, and we don't expect it to increase in your average person. So they looked at people who were under 25, and it increased by 0.38 in the inertia, in the early initiate, so before 25. And then if you start after 25, then it grew 1.03. Okay, so both of them agreeing a little bit, but that's compared to what it'd be if you were not treated, which would be 4. So it's kind of like, if you weren't treated at all, it's going bigger, faster. If you're treated before, after 25, it's still increasing, but not as much, like a fourth of what it had been if you hadn't been treated. And then if you're even under that, it's even lower. So really what they found here is that early treatment with agalsidase alpha as an enzyme replacement therapy begun before 25 improves heart and kidney outcomes. So what we're looking at. Yes, thank you. Left ventricular mass index is its official name. Do you see the got it? All right, but basically it's telling us how much the left ventricle is growing, right? Compared to how big you are. So that's why it's not just how big it is, it's how big it is compared to how big you are. Bottom line here, they felt that based on this data, which is a large data set, that starting therapy before 25 was helpful for the heart and kidney. And starting therapy at all, even after 25, was still better than what it would be if you had no therapy at all. All right, so early treatment in kids is a bit better. Early treatment in men is better. Well, let's take a quick detour. Let's go to Canada, where you guys already are. As you guys know, there's a big study that's focused in Canada. It's the Canadian Fabry Disease Initiative. And this gathers data from all the centers across Canada who are treating their patients. And their question was, is starting therapy at an earlier age helpful, or is it starting therapy when you're sicker more helpful? See what I'm saying? They're saying, is it age or is it how sick you are that means you should start therapy or not start therapy? And that's how they built the guidelines in Canada, was to look at symptoms, not looking at age. So they were looking at those other studies, like the ones we were looking at in the slide before, where it was saying, should you start at age 8? Should you start at age 25? Where should you start? They said, well, let's look at our data and see what our data says. So they found 25 patients who are classic Fabry disease and on no treatment. This is men and women. And 30 patients who had either enzyme or chaperone therapy. And their question was, how many of these folks, treated or untreated, had what we call Fabry clinical events? This is the stuff you don't want to happen, right? Kidney failure, kidneys worsening, heart problems, getting a pacemaker, hearing loss really fast, stroke, and death. So that's when we say Fabry clinical event. They're like, okay, if you started therapy under 25, if you started therapy period and you were under 25 versus didn't start therapy, what's the rate of one of these events happening? And so when they looked at the treated event, there were 8 events and 4 for guys. It was 4 kidneys, 2 heart, 2 neurologic. So they overlapped, right? So one guy had multiple things, 2 guys had multiple things. And women, 2 of them had strokes. And when they looked at the untreated group, they found 3 events, acute hearing loss in 2 men and 1 woman. So they looked at these numbers like, oh, they both had events. Yes, they did. And so their conclusion from that was that critical events happen in males and females even when they're on therapy. So, okay, that's fair. And then they said, well, what are how long did it take for these events to happen? So if you were not treated, then it took some of these events happened when you were 13, and when you were treated, some of the events happened when you were 28. But that's the average, right? So it happened at a range of times. And then the event rates. So what's the rate per 1,000 patient days? What was the rate? So if we looked at the rate of event happening per 1,000 patient days in patients who were not treated, it was 0.0043 and treated was 0.05. Okay, now that doesn't mean that much, right? When you think about it, you're like, what does that mean to me? How does this even impact things? Well, their summation was, they didn't think that earlier therapy seemed to consistently make a difference. And they think their guidelines, this supports not doing therapy in young men with classic Fabry disease who are asymptomatic. So this is different than the other 2 studies we just saw. And when I look at this endpoint of Fabry clinical events, and I look at the age of the people they were looking at. So they're looking at people who started collecting data on them when they were under 25. And then they looked at data from 2007 to 2022. So these are still young individuals. So the oldest they could have been was like 25 in 2007. So then they would be in their 40s in the very latest, right? Late 40s at the very latest. So I think maybe we're not seeing the full picture from this study. I think maybe you could slice and dice this data a different way and maybe see a difference. And I wonder if there were just not enough patients who started treatment under 10 or under 15 or under 20 that could be compared to each other. So it's got a lot of data in this Canadian Fabry Disease Initiative, and I think there's a lot of cool things that come out of it. I am not sure if the way the critical events worked for this particular paper fits within other things within the literature. But again, like, I'm not looking at the data from the whole database, so I can't tell you if there's a way to look at it in a different light. But worth talking with your doctor about. You could say like, hey, I saw that study that came out of the Canadian Fabry Disease Initiative summed up, and to them it looked like earlier therapy didn't make sense and didn't change things that much. Or do you have a different thought about it? And just see what they say about it. That same data set that we talked about, not the Canadian Fabry Disease Initiative, but the one before that, this big giant international database that looks over at 19 years of data. They looked in to see what happens when you've been treated with agalsidase alpha over the long haul. And they had 66 patients who'd had treatment for over 19 years. And most of them were classic Fabry disease patients. They did have a few deaths, around 57 years. But in general, they found that that left ventricle mass index and the eGFR was much better and slowly progressing than people who were not on therapy. So that was just more good news showing that over the long term, over 19 years of data, it helped with the heart and kidney. So. Okay, so in migalastat, I show you this image just because I think it's a really cool way of showing you how the mechanism works. This was a publication that came out basically about a year ago. And I like it because it's showing the different ways that migalastat can help things. There were a couple different chaperone therapies or proposed chaperone therapies they were talking to us about at the World meeting, but nothing that was far enough along to really think about. So I think in this case, migalastat, which is a chaperone therapy that's galafold, so it's approved for use if your doctor prescribes it, works in this way. So you've got your enzyme, and your enzyme, if you have certain mutations that are amenable, are making an enzyme that doesn't work in different ways. And there was a great talk about this, that it may be because the enzyme has a problem with the way it folds in the active site, and maybe an issue with how it gets quality controlled when it comes out. It may be an issue with, I can't remember them all. Anyway, there's different ways that your enzyme can have problems, and the ways that it can get the chaperone therapy can bind to it, get it through the quality control Golgi apparatus, get into the lysosome and help it break things down and then get out again, which is basically what we're seeing here. We're seeing this enzyme being made. We're seeing it go through the ER, go through the Golgi apparatus, which is more quality control, and getting it targeted into the lysosome where the migalastat drops off again. And so that then the enzyme, even though it's a little bit wonky, it's working enough that it can then go and break down the GB3. So we're trying to impact the folding and try to get it into the right place so it can do its job, even if your enzyme is a little bit, wouldn't work on its own as well, because the quality control would rule it out. But just know that they're working on different ways that migalastat works on different mutations or pathogenic variants, and they're trying to figure out which one's more amenable or less amenable, but it's all working through this same process, just trying to get it through the quality control and help it work the very best it can. Now, remembering that lots of people have non-amenable mutations, which means their enzyme is so broken or so stubby or so not available that even having migalastat around it is not going to help it support it. And that's why some people are, migalastat isn't an option. All right. So what about therapies that are in clinical trials? Well, we talked about migalastat now. So that's one that works with people whose enzyme can be supported so it can still do its job and get it through the quality control system. There's enzyme replacement therapy that we talked about, and its whole job is to just go ahead and replace what we're missing and give it through your arm by IV every 2 weeks. And then there's a couple other options. One of them is gene therapy. Gene therapy's job is to, in this case, for the two that are there, use an adeno-associated virus to get it into the cells of the body and see if you can have that particular organ it's targeted, make itself into like a little enzyme factory. So the liver, the heart, wherever it's supposed to go, see if you can basically infect those cells with a non-dangerous, theoretically non-dangerous kind of neutered virus, and see if they can get the enzyme to express itself from your cells, but not integrating itself into your DNA, just doing it separately. There were some great presentations about different types of gene therapies, some data from there, so I'm going to talk to you about that. There was some data about a next generation enzyme replacement therapy called pig unigase alpha. There's a couple of studies they talked about there. And then there was not as much about substrate reduction therapies usually would have. The goal of substrate reduction therapy is to try to take the things that the different molecules that would store up and cause GAB3 and take them out of the equation earlier, kind of like trying to get off a local street and not getting stuck in a traffic jam on the expressway. And there's a couple they talked about there, although they didn't talk about lucerastat or venglustat at this particular meeting for Fabry. Okay, Dr. Hopkin, who I know many of you know and love, he gave a presentation on this first gene therapy. It's called ST920. This is an adeno-associated virus. So basically, you get an infusion, a one-time infusion and it goes into through your bloodstream and targets the liver cells, and it puts a little circle of extra DNA that makes alpha-lactosidase A in the cells of your liver. So they found a dose that they would like to use that has minimal side effects. And this picture is just showing you how far that enzyme is going up. So these original people, so these are 12 people, all these folks had classic Fabry disease. So they had no enzyme or very little enzyme. Oh, there's one woman. So she had little enzyme. But you can see in this graph that gray bar down the middle or down at the bottom there, that's normal levels of enzyme. So what they've been able to do with this, giving this gene therapy, is get everybody well above normal levels of alpha-lactosidase A. And this is, you can see at the bottom, that's number of days. And these are some of the participants. There's more. There were some people who did lower doses. There's like 5, 6, 7 people who did a lower dose of enzyme. And this is the dose they're looking at now. And they've kind of decided on. So this is the ST920. But you can see whether they had gotten off enzyme, they were on enzyme, or had never been on enzyme. Their levels went way up high and then started to come down again. And hopefully they'll normalize out kind of in a plateau. Doesn't matter if you get enzyme up and your GL3s, the lyso-GL3s doesn't stay down or be normal. But you can see here, this is people who were on enzyme replacement therapy. You can see their levels didn't increase. They stayed with the same as they had, even when they got off enzyme replacement therapy, except for this one at the end. You can see participant 1, you can see how the GL3s did go up after they stopped enzyme replacement therapy. But everybody else stayed nice and low, even though there were some bumps. There's always bumps, but you can see things were pretty stable there. So alpha-lactosidase enzyme up, lyso stabilized or lower. That's good news. And there weren't any serious issues. So one of the things you want to know with gene therapy is, how did the immune system react? And the immune system said, we see you there, by giving people fever, headache, and chills, some increased burning pain because that fever, as you guys know. And there was one person who had sepsis, which is a whole body infection. But overall, nobody had massive immune response that caused problems for individuals. And nobody went on, at this point, had gone on steroids, which is what you give people when they have immune response to gene therapy. So that was good. So looking at the enzyme replacement therapy, the one that's in clinical trials right now, and is actually going soon to be looked at to see if we can do it can get approved for marketing, so we could order it up at the pharmacy, is called pig unigase alpha. We used to call it Unigal. It's going to get a new name someday if it gets approved. But the difference between this and an enzyme replacement therapy that's already available, it's got this little pegylation on it. This is just this kind of molecule they stick on the end, and it helps it stick around longer, and it helps the immune system ignore it. I kind of think of it like the invisibility cloak in Harry Potter. It's not perfect. You can still see things sticking out, but it helps cloak it so your immune system is not so likely to consider it a problem. And the one study that they showed us, a couple of studies in a poster that they showed us there, they were looking at antidrug antibodies. Remember we talked about that. That's what your immune system does when you give it enzyme replacement therapy, because your body's not so used to having high levels of alpha-lactosidase A in it. And what you make of those ADAs or antibodies. And what they did is they got people's blood who have Fabry disease who'd been on enzyme replacement therapy, and they looked at the antibodies in their blood. And then they looked at it and said, okay, what happens when you've got an antibody to alpha-lactosidase A, or sorry, agalsidase A alpha or agalsidase beta, and you put it with an antibody that's pegylated? Like, what does it do? And the news is that they both react, right? And whether you're getting therapy with any of these enzymes, most people are going to make some antibodies. But they did see that when the pegylated enzyme is put in the test tube and they look at the activity of the enzyme, that the pegylated version allows the enzyme to work a little bit more. So higher enzyme activity in a tube. When you've got a bunch of antibodies that are not pegylated, so agalsidase alpha or beta, you're still making enzyme. Enzyme is still happening, still working, but it's a lower activity. The bottom line is here that when they looked in a test tube, they found that the peg-unigalsidase seem to have less antibodies and impact the enzyme less. Now, this is not in humans. This is just in test tubes. So take it with a grain of salt, but just know that that's one of the things they're going to talk about is that when you look at using this next generation enzyme replacement therapy, the hope is that you'd have less of an immune response. Again, remains to be seen, right? So what they did also have done for a long time is they talked about the data for 2 different ways of giving their drug. So one of them is called the BALANCE study. And this is a study that looked at people whose renal function was getting a little bit worse, a little bit worse, a little bit worse. And they gave them either agalsidase beta, that's fibrazyme, or they gave them peg-unigase alpha. And you didn't know which one you were getting. So you got one or the other and you didn't really know. But 52 patients got study drug and 25 were on agalsidase beta. They looked at the immune reaction. So they looked at how many people had IRRs, that's infusion reactions. And they found that in the study drug, you had 13 immune reactions in 11 patients. The agalsidase beta, you had 51 reactions in 6 patients, which tells you 6 people were more likely to have infusion reactions for sure there, right? And they found that there were antibodies formed with all the different enzyme replacement therapies. And then they saw stable heart and they saw stable lyso levels. So what does that tell us? That tells us that this medication appears to work as well as agalsidase beta. That's cool. We're cool with that. But we did find, I'll show you in the next slide there. So on the other study they did was they looked at patients who are on agalsidase beta or agalsidase alpha, and they switched them to the study drug. So everybody knew what they were getting, and they gave 2 milligrams per kilogram every 4 weeks. So that's 1 infusion a month instead of 2 infusions a month at a higher dose. And they said, are people stable? Or are they having more immune reactions if this is the case? So they'd already done a 1-year study, and then this other study is 2 years. So that's 3 years of people on 1 infusion a month. They found that people came in with antidrug antibodies, they left with antidrug antibodies. So they didn't get more or less in that case. All the infusion reactions were mild or moderate. And after 3 years, everybody's plasma lyso GB3s were still stable. So they weren't getting on average, right? Some may have bopped around, but on average, everybody stayed stable. And that's nice because that says there might be for some people the option with this medication to do it once a month instead of twice a month. But again, this is just on 29 people. So on the whole, this tells us that this new drug that is getting looked at to see if it would be an option for people with Fabry disease, they found for people who started having kidney problems, that this level, they were trying to see if it was better at making people have renal function that was decreasing. And they found that it's about the same. And when they switched to see if somebody would have more problems with their immune system, it didn't have increased problems. So that was good. So what we're looking for, is it safe? Is it effective? Is it as good as agalsidase beta? And the answer was, looks like it. And then switching to every 4 weeks with the new study drug, is it about the same as people who did agalsidase alpha every 2 weeks? And the answer is, looks like it. So that could be nice just as an easier option. Substrate reduction therapy is the name we kind of call these class of drugs that are pill therapies. And their job is to basically try to get all the gunk that would build up and cause GB3s to form and to stick around and try to get them out of the body earlier. And that's what this pathway is all about. It's just saying, hey, if we could get like some of the molecule bits out when they were glucoceramide or lactoceramides, they didn't build up to be globotriacylceramide, would that be better? And there is already approved drugs in Gaucher disease, which is like our sister disease, like Fabry's sister disease is Gaucher disease. They have some FDA approved ones for them, and they're trying to figure out if it's safe and effective and works in Fabry disease. There's one therapy that's done that was Idorsia, and they're trying to figure out what to do because they used pain as an endpoint and they didn't meet their endpoint. So they're trying to figure out if they've got other data that would be helpful so they could use it. Sanofi Genzyme has one out that's in clinical trials right now, looking at how well their pill version of this works for pain or works on the heart, 2 different studies. And then there's a third one that they're just talking about. So this is a different company that's not been in the space before. and they're developing a drug they call ALO1211. And they are looking at this because it doesn't go in the brain. And you might say, but we want things to go in the brain, right? We know that there's Fabry fog. We know there's there's brain things. But if you are a little kid and you're developing, we don't want to mess with what's going on in your brain. So I think they're trying to come in and say, this one doesn't penetrate the brain. It could help do the body. Maybe this would be okay for little kids. Because the other ones, they are working gauche to try to test in little kids. But it's something that people are concerned about, because one of the things that your brain is busily working on is all of these different molecules. So brains need ceramides, brains need glucoceramide. They want all these things in their developing brain. So you don't want to decrease levels. So they're saying, well, if it doesn't go to the brain, is that a good thing? We use it pediatrically? Who knows? They've given it to people in phase 1 and just standard human volunteers. They're going to start giving it to people with Fabry disease, just to see, not kids yet, just people with Fabry disease. They said they're going to start that this year. We'll see. I have not talked to them. So the other gene therapy that's adeno-associated virus that's further along is done by 4DMT. Is the name of the company, and the gene therapy is called 4D310. This one is targeted the heart, which sounds cool. And they started a phase 1, phase 2 study. They started out with men and they added women in down the road. And they were looking at what does it help the heart? And so the data they presented was looking at 3 patients who got to 12-month follow-up, and they didn't find any cardiotoxicity. So that means nobody's heart got really big and caused problems, no big immune response that affected the heart. And they found, one of the things we measure on a CPET or an exercise test is, what's the peak rate of exercise that you can do, right? And so they found that in 2 of the 3 patients who got to 12 months, they were able to exercise longer, which is great. And they didn't see other problems with it. The one thing about this medication, this particular enzyme replacement therapy, this particular gene therapy, is that it did have some immune system responses when they gave it to patients. And so they have this study on hold right now as they figure out how they want to handle the immune responses and how they occurred. So at this point, they were just reporting on their positive cardiac effects, and then they were trying to figure out how they're going to handle some of the side effects that came from giving this medication. Even though gene therapy sounds very similar, where it's targeted and how it works is going to be very different. There's another company called Freeline that's also targeted the liver. They have presented good data in the past, but they've been doing most of their studies outside of the United States. And I didn't see a poster for them at this meeting, but just know there's another company who's working on it as well. So different companies all racing to get gene therapy right. You probably remember AvroBio that decided not to pursue doing Fabry before, and that was a different kind of way to do gene therapy. That was when they took someone's own cells, put them on, went and transferred them in a test tube, basically, and then brought them back and injected them after they dampened down your immune system. And that one had some good results in Canada, went to Australia, they changed some things around, it didn't seem to work as well, and the company decided not to pursue that program anymore. So that one's kind of like not something that's active and going right now, but gene therapy is definitely happening right now. And the question is how effective it's going to be, what are the side effects going to be, how long is it going to last, and is it going to be helpful for how you feel as well as anything else. All right, that was like an info bomb. So I'd be delighted to answer any questions. I'm happy to clarify anything that was on there. I know some of those slides were not pretty. They were just chock full of information, but not pretty. So I'm happy to talk about those as well. You can put it in the chat questions, or you can just ask them, whatever makes you happy. As you might expect, so we were sitting there and all this information is going into our head. And then we would go to these posters and all the information would go in our head. And then we'd go and talk about it to be like, did you read this poster, Julia? What do you think about this? Donna, did you see that poster and presentation? What do you think about that? So there's just a lot of discussion that goes on in these meetings, which is, I think, sometimes just as important as going to the things. So we've got a comment here. It's always a little bit the same with every company. They race to go first for the best drugs. That's good, but I wonder how it would affect research if some members actually were affecting with some severe symptoms, just wondering. Totally agree. I think that if you had a family member who had Fabry disease and you were trying to figure out how to treat them, you would be going for the best drug. You wouldn't be just doing the race, you know, you would try to figure out like, what's the best, what's the most effective, and then you wouldn't keep developing if it wasn't. And unfortunately, what we look at is that most of these companies, not like Sanofi and not like Takeda, but most of them are startups. And so they have to answer to their people who gave them money to do the studies all the time. And they have like a limited amount of time to try to show that it works. And I think sometimes that leads to not the best experience for people doing the studies or the people running the studies. There's a world, yeah, exactly. The difference between understanding and living with. And I think actually that study I showed you where they asked you guys about what was going on. I love studies like that because that digs in to say like, do you care about having another therapy? Like, how are you feeling, guys? Like, what do you not know about? You don't know about antibodies? Well, if you know, a company is going to make everything they talk about to antibodies, then it's not going to be very effective if you don't realize that they check your antibodies and why antibodies might be a problem. And I would say, you know, in Fabry, we hadn't been paying too much attention to antibodies for a really long time because so many people had it and they were still doing well on therapy. But then when we started looking closer and we started being able to measure neutralizing antibodies, and that's where we're like, ooh, some people could really use another option. This is not working as well as it could for some people. The other thing I didn't mention is that for Galafold, which is migalastat, we don't measure antibodies for that one because it's not an enzyme. So enzymes, your body's making an immune response to because you have such low levels of alpha-galactosidase A. So your body's like, this is a foreign thing. For Galafold, it's not activating your immune system because all it's doing is stabilizing your enzyme that you already have. So that's handy. So let's see.
Dawn, there's actually a question that there's a few people that messaged me personally. They were wondering if they wanted to get their antibodies checked, and I don't know, it might be different in Canada, but if they are doing them already before and then measuring them again after their infusion is started.
Yeah, so typically what all of your doctors do, and probably that's right there in that Canadian Disease Initiative, is they're measuring your antibodies. It's just that you don't recognize it. If you've ever seen a gold top tube be pulled from your body, that's probably your antibodies. Because those serum separator tubes, sometimes we do cholesterol, sometimes we're looking at your kidney function, but usually if you've got one dark green tube and one dark yellow tube or gold tube, those are going straight for your GL3 biomarkers or your GB3 biomarkers and your antibodies. So what you can do is you can ask your nurse, your genetic counselor, your doctor, and be like, hey, have we ever measured my antibodies? And if they haven't, then you're like, okay, can we do that? In the United States, and probably up where you are too, they're provided for free. So it's not as if you've got to worry about how it's covered, like out of your pocket or insurance or whatever. It should be covered as whatever's going on.
Yeah,
I
believe it is. Yeah, it's covered. And I think the question is that sometimes it's just lumped together with just your blood work when you were at your doctor. So I think it's a good idea to just ask, you know, have my antibodies been checked? And if so, I think what you're looking for is not so much a number, right? It would be a positive or negative, or is that?
Well, they give you a number, but you actually just want to know if it's positive and negative. And because sometimes when you've had enzyme for a long time, you may get levels and then they go down over time. Or you may get high levels of IgG and then you'll maybe get some neutralizing antibodies too, but then it may decrease or it may get worse or it may stay. It doesn't actually correlate with whether or not you had infusion reactions though. And I think that's where it's confusing. It's like, well, if my immune system's really paying attention, then why am I not having antibody reaction? It's, you know, why am I not having like rigors or chills or anything like that?
I'm pretty sure it's a requirement to have a checked starting enzyme. And then I know for a fact they check mine every 6 months or a year. I may be a bit different where I did the gene therapy, but I definitely get checked at least once a year.
Yeah, and most people do. It's just they don't tell you like when they've got your tubes. If you ask, they'll be like, this is for this, and this is for this, and this is for this. But if you don't ask, you're just like, there goes my blood. Have fun, blood.
And then another question kind of around that was someone was asking, do symptoms in between infusions, so when you're mentioning that there's the symptoms that are happening in between, does that suggest having more frequent infusions?
So when it's approved and then you're on something like the Canadian Fabry Disease Initiative, they kind of have a schedule set out and they're not going to change it. But in the United States, we have a little freedom with dosing. And I do have some patients that I do on weekly infusions of 1 milligram per kilogram. So we've seen improvements for at least a couple people we've tried. We tried it with one person who saw no improvement at all. So, you know, and then there's other people in the United States who do all sorts of interesting dosing things. I was just talking to somebody the other day, and they said they gave 2 milligrams per kilogram every week. And I was like, whoa, how'd you get insurance to pay for that? Because here in the United States, that's all we care about is how did insurance get to pay for that? And he said it wasn't a problem. He just told him what it was and what was going on. So yes, it means that some people may benefit from somewhat more frequent dosing, but depending on how you're getting your drug, you may not be able to access that right now. But it does mean that if there is a enzyme replacement therapy that sticks around longer, maybe that could help. And I think that's part of the marketing that they're looking at, and then the studies are looking at. Is it decreasing? Mind you, they've got to look at this, right? Is it going to decrease what we call those breakthrough symptoms if you have a drug that sticks around your body longer? Because we know that pegunigase alpha stuff does stay in the body longer, like agalsidase beta, agalsidase alpha. The liver sucks it right up and uses it right away. That's why if you stop your infusion and you're having a reaction, it goes away pretty quick because your body uses it really fast. Pegunigase alpha sticks around longer because of that pegylation. So the question is, okay, it sticks around longer. Is that better? Or is it just that it sticks around longer? And that's what their studies are looking at. All right, we got some other questions here. All right. I think we will see some major shifts in Quebec since the doctor and nurse initiated the Fabry research trial might retire in the next year. I know this makes a few people nervous here. It might impact research in the upcoming years. I'm the first one to receive Fabrazyme in Quebec, and I can sense that they aren't as open as they were to new therapies, and we'll see. But I do hope to be able to test other futures in the future. And then your English is great, so don't worry about that piece. When I think about how we grew up in Fabry disease, right? So when Fabrazyme or agalsidase beta was first approved, it was like a miracle, right? Anybody could get on it, you wanted to get on it because they were seeing that it could really help. And that's what we saw in those studies we're looking at, that being on it helped. Is it perfect? No, but it helped. And I think, unfortunately, it meant that some people who treat patients with Fabry disease just hooked onto it and stayed with it. I used to call them Genzyme shops. So they just weren't as open to trying new things because they saw that it worked pretty well, it was pretty safe, and they had so much experience and so much support to give it. In the case of Canada, as you guys may remember, sometimes you couldn't even get enzyme, like during shortage time, sometimes during other points. So the study that they created is to basically make sure there's a steady supply of enzyme as much as they can. And I think by locking in with that, it also gives them kind of tunnel vision, like this is the guidelines we came up with, and this is where we're going to work with. And so it may be interesting to see as you get new physicians, how they look at it. You still want that level of expertise. You still want that level of care that you get. But sometimes, sometimes people can open their minds a little bit and just kind of think about other ways of treating. Now you have some amazing physicians who are like, came up with entirely new places to do things, right? So I'm not saying that as a blanket statement. I'm just saying all of us get set in our ways over time, no matter who you are. And that goes for treaters as well. So you're right. There may be different changes in how you look at treatment. There may be different changes, good or bad, in how you get your care. You always want that person who has that compassion, which is so important too. So that's where you kind of like weigh all the pieces, and also where you can go to get your Fabry expert care. Oh, we got a good night from Carolee, who's heading out. Newspaper articles where I was interviewed about possibly Fabry being shut down. Yeah, 2004. That was just painful. I just remember talking to somebody at a meeting, like one of these world meetings, and they're like, we can't get it at all. And I was like, oh my gosh, this is a travesty.
Someone else is asking if you can explain just specifically what an analog is.
An analog, yeah.
That would be
yeah. It's kind of funny, right? So GB3s, let me see if I can. GB3s are this great big molecule, and it's a big complicated molecule. It's got all this stuff on it. It kind of looks like this, right? Ignore the pegylation part. But oh wait, not that. I had a picture of the molecule up at one point, and then I took it away. Okay, this doesn't show the picture of it though. Okay, look at it this way. You remember those like, let me see, what's the best analogy I can think of for this? Okay, Let's think about the boxes we get from Amazon, right? So we've got different boxes that come for different things. So let's say we're ordering boxes of chips, and you usually get your boxes of chips in a box that fits them exactly, right? So let's call that regular GB3. So it's just a big molecule, and it's not getting broken down because our alpha galactosidase A is not making it work. But there's different ways, different boxes we can have. So we can have a box that says like Amazon, it's got a smile, but you can have another box that's like, comes from Amazon, but it's just the box of chips on the outside, right? It's got the same colors and it's shaped a little bit differently, but it's still a box from Amazon that has your chips in it. That's kind of like what analogs are. They're molecules and they just have slightly different changes in their chemical structure. So they may have a hydrogen over here, or they can have an acylated group over here. And it's just that there's something slightly different about the number of pieces that are in that molecule. And so when they make an analog, they're like, here's our normal GL3, like, or GB3, like everybody thinks about. And they're like, okay, minus 28 means it has slightly less of what made over that GB3. Plus 16 means there's another piece, that molecule that got added on that made it slightly bigger than what your standard one is. Plus 50 means you've got an even bigger piece. And the way that you do them is we put them in this big machine and it breaks down the molecules, and then it puts them out in different patterns. And that's what you usually see is how much of this GB3 that's the same GB3 as it, or how much of the GB3 that's slightly smaller or slightly bigger or just slightly different in its shape. And it's trying to measure them all out. So it's kind of a weird concept, but just think about it being like your Amazon boxes. Each one of them can look slightly different, but they're all stuff that builds up in your body. It's just that when you try to measure them or weigh them, it looks a little bit different. So it's just in our body, things don't just hang around, they change all the time. And these are just different ways of things that slightly changed or altered when they were being formed in our body. Not bad ways, these are normal variants. Everybody's got them. It's just that they're trying to measure each of these different types of this molecule to see if they can figure out what somebody might be having more problems, less problems, or might have. They're actually trying, at one point, they were trying to see if different of these related to different organ systems. So like, is the bigger one related to the heart? Is the smaller one related to kidneys? Nothing there's really panned out yet, but that's what they're trying to figure out. You know, is it different organs, different parts of the body that relate to some of these analogs? And there's some great articles that Christiana Ariblez has put out that really looks and tries to dig into this issue. And she really thinks that looking at the patterns is going to make a big difference. All right, I see a hand raised. You can unmute you and you can talk. Go for it.
Hear me?
Yeah.
Looks like I'm the only one at typing and speaking. So,
You're like, just let me talk.
you're gonna see my English speaking is probably worse than typing, but anyway.
Better than my French.
But, yeah, probably. With the research, I spoke with Donna, I think probably 2-3 weeks ago. I've been under some radiotherapy treatment, and I know it's always hard with us with Fabry because we have so much things going on with the body. You know, it's hard to do some clear research. But for my my intestinal problems, I'm a very affected Fabry patient, and while I was receiving the radiotherapy treatment, it's for my lips and the neck. I was able to eat everything I want. I had no problem at all with my, well, a little problem, but you know, was able to eat like ice cream like I would never do before.
Mhm.
And I think it was for probably all the duration of the treatment for probably like a month and a half, and nobody knows why. So nobody have it. And I think, like I said to Donna, I said, is there any way that this data can be shared to other, you know, physicians, because maybe there might be a key in that and what happened to me, how I don't know how the stomach react or whatever. I don't suggest that everybody should have a radiotherapy, but there's definitely something that I've worked with me and nobody can, you know, can pinpoint out what is it exactly. And just after the treatment, I had like 3 severe crises, abdominal, like three days back, and still it keeps coming good. So for the last 2 months, I'm not able to eat as much as I would love to while I was doing the same thing in radiotherapy, but I'm still better in that way. And I know that it's not a treatment because I've been like under Fabrazyme for probably like 20 years.
Mhm.
So there's something in that. And I don't know if there are some people that keeping track of those things that affected us. So, and for the research, it could help, in the next years or whatever. So,
Yeah, you've got a very good point. There's the way that we try to get that information out is by doing case studies. And so at the World, we have lots of posters that are 1 patient, 2 patient, and people say, here's what we saw. What do you think? And that way other people could say, oh, I also had that same experience with my patient. I
Right.
think one of the things that is critical there is partnering with, your doctor or CDA to see if that's something that they'd like to put out there on a poster. It doesn't have to be fancy. You put in an abstract when they call for abstracts and you say like, this is what we saw. Gastrointestinals were better during radiotherapy. And then people can think about it. Like, what is it about radiotherapy? Does it decrease this? Does it decrease that? How does it affect the immune system? We do know that some people, when they go on steroids for another reason, which means their immune system is a little bit calmer, sometimes will have improvements with some of their pain and can have some improvements with,
That's
some of the
awesome.
diarrhea and stuff too.
Right. And I actually explained to Michelle that he should talk to Dr. Bichet about that. And I'm sure he has. So that's
Then
just
Yeah, I
really
know Dr.
interesting.
Bichet is one of our folks who's also heading out for retirement too, but he does go to World, he does go to these meetings, and I bet he'd be willing to chat about it and see, if nothing
Right.
else, he can ask other people.
because it's the same thing, we have to answer like a survey or a form every 6 months.
Mhm.
And I've been talking about that for a lot of years. There's no one that asks about sleep disorder.
Mhm.
And I think it's one of my most, principal fight. And I talked to Dr. Bichet and with the nurse there, and they always told me that, it's because you worked on night shift. It's because of this or because of that. And one of my cousin have experienced the same thing. And so if you take each individual, it's hard to make a whole and to see the global image. But I still ask, and I know I speak with to Donna about that also, but is there a way in the research to just improve, the form and add other stuff? Because in my surrounding, I think everyone that is affected with Fabry disease can't sleep or had
Yeah.
trouble some sleeping or, so it cannot be coincidence every time. So it has to be. And when you do some research, that's what I thought, because I have worked in the medical field. If you grab everyone, everybody on the same place, it's a little bit easier to understand that maybe there's something going on with Fabry about the sleep disorder or whatever. It cannot be always individual related. And I spoke with the Derbyshire I think last year, and I said, because when I take some kind of medical some kind of drugs, I have some it's not sleep disorder, but it's like I can go crazy, in my sleep or whatever. And we established that it's like it's not a pineal gland, but I think it's one of the gland that you regulate, usually the sleep, the sleep cycle or whatever. And
So you're actually on the right track. And we have found there's been a couple of studies that came out that were looking at sleep and how your so you're thinking about pituitary, right? Pituitary and your axis with your thymus. They've looked at how that all interacts, and it seems that the circadian rhythms in Fabry disease, which is why you sleep or don't sleep, are off. And so that's something that needs more research into it, and people are starting to pay more attention to it. So the forms, the CDFI forms are IRB approved. The chances of getting them changed are very small, but the chances to do something outside of that is where you've got to get much of people
but
together.
when you get them change, this is where I think there's a major shift after that. Because if you have, I don't know, in Canada, I don't know, maybe 200 Fabry patient, and on the 200, there's 90% or 95% that can sleep. Now you can say, okay, now we have a problem, and
Yeah, for
you can
sure.
be able to to derive some research for that. But as long as you keep that individual, it's always hard. So it's the same thing for the heart. I'm the only one in Quebec that I've gone under surgery for the AF, problem.
Mhm.
And there's no doctors in Sacré-Cœur that want to operate, to do the surgery, because they all think that it's not working and it's not efficient. And I found one doctor at the CHUM say, okay, I think I'm going to be able to do it. And he decided to do it. Is it working?